Thank you so much for inviting me to give a talk on where we are now, and a lot of good news. And it has. I will take you through. Can you see my pointer? Yeah. So I'm Dr. Rahul Singh. I'm consultant pediatric neurologist. I work at Guy's and St. Thomas's Hospital and have been very closely involved with development of this new service, which we are going to talk about. And you can see this new logo. I will tell you what it is. And as historically, Alex TLC had been so helpful and very deeply involved with weekly meetings with NHS England, which is still going on. So good news is that NHS England, they have approved new services for inherited white matter disease, which I'm going to talk about. Before I start talking about it, just a brief recap. What is inherited white matter disease? What is leukodystrophy? It's a progressive white matter disease with heredofamilial genetic cause, which ultimately leads to dysfunction, destruction of white matter. This can happen in stages. Yeah, as a parent, you would have seen with your children or in general, not all leukodystrophy follow the same pattern. They can have stuttering course, they can have relatively stable course. And I remember Fia and Lian both. I have done this journey with Fia since I met her. She was my first patient with leukodystrophy. And I've seen her, how much she had gone toing and froing for the diagnosis. And there is expertise in UK. A lot of our neurology colleagues, they all have dealt with it. But bringing all of them together was a big challenge. And there is no reason why having so much of expertise here, and we have everything, why we couldn't bring all the service together. So I am still doing this journey with Fia, and I have met with her last week, and we are looking forward for the trial. She has got Alexander's disease, and she's doing well at the moment. And before we come to that, this is a study done by Professor Chris Verity, one of our neurology colleagues based in Cambridge. And since 1998 till 2014 or 15, he was the only person who collected all the information about children with progressive neurological deterioration. And in different age groups, less than 1, 4 to 10, I think it is another subgroup. This is less than 10. You can see that he had around 1,500 patients. Out of that, around 500 had diagnosed leukodystrophy. Then he classified some of them having leukoencephalopathy. And if you look at the diagnosis wise, what I'm trying to say that in leukodystrophy, inherited white matter disease is everywhere. We didn't have a pool where we can have information about all the inherited white matter disease, all ages, so that in 5 years' time, 10 years' time, 20 years' time, we can make an impact. We can provide them with a good quality of life. And if needed, they can be recruited in the trial. We will talk about trial at some stage as well. And I'm so thankful to Suzanne that she updates me. I try and contact the team if there is a new trial coming up. I try and share those information with VPNA, wider VPNA colleague. And one of my role is I am chair for the specialist interest group for genetic inherited white matter disease as well in the UK. So I am passionate, I am involved, and I want to take this work forward along with my other colleagues in UK or nationally, internationally, whatever it takes. So who are we? So this man, Professor John Livingston, you must have heard about him. He spoke about registry yesterday. Sorry, I couldn't attend that. I wanted to attend that meeting. John was my educational supervisor. I have trained under him. What a fantastic man he has been, and how much hard work he has put in to bring leukodystrophy service to the UK. So all credit goes to John. We as a team, I have been involved with these people very closely in the last 3-4 years as a consultant, but I'm sure there are a lot more people who have been working on this for years, because Department of Health in 2008 gave a proposal about rare diseases, and since then they have been John and other people are working for it. So it's not just neurologist who deals with it. There are metabolic physician involved, neuroradiologist involved, geneticist, genetic scientist, and especially in this age where we are getting whole genome sequenced and we are getting better information, better genetic data, I'm sure there will be new leukodystrophies coming up, like we will diagnose them, and support nurses, support staff, and everything. And most important is Alex TLC, what you guys have been doing now, and Metabolic UK people, other support UK, and the researchers. So, and I have seen Bernie Stokes, how much passionate she is about this service. And every week we have meeting, every 2 weeks we have meeting, dedicated person working hard, trying to get best of this thing. Sally Kavanagh is also from NHS England, Arden and Jem unit, who is going to be one of the where the registry will be based, and the whole NHS England team. So they have all come across. And in the last 3 years, they wanted a small number of separate but collaborating pediatric and adult inherited white matter disease centers. So to develop sort of disease-specific protocols, pathway, how do we get to the diagnosis soon? What is the optimal management? It's not about trial. Even other symptomatic management and symptomatic supportive management were equally important. And these centers will support the inherited white matter disease centers, and also to have a registry which will capture all the information about patient, not just about diagnosis. Most of the scientific registries are clinician driven, research driven, but this registry I feel is unique because it is patient driven and clinician driven both. And Sarah, Karen, they have worked relentlessly to get what we're still in the phase of formative phase, but we will talk about that later. So the bidding was first bidding came up in June or July, and now there was one bidding window period was in September that finished. They reopened it, and that has closed as well. So the expectation from NHS England was that we needed appropriate expertise. You needed to have a consultant neurologist or pediatric neurologist, consultant neuroradiologist, geneticist, metabolic person, genetic lab person, and other support, nurses, psychologists, and data manager. So we are expecting 30 new referrals per year per unit. And the aim is to, if you look at this, wherever the referral comes from, ultimately everything has to be in the registry, so that in 10 years time we are in a better position to understand our population, how they are doing, and what else can be done. So we needed appropriate clinical support, access to specialties to support the management of patient, palliative care, appropriate infrastructure, ring-fenced patient clinical facilities, and other thing, and appropriate research infrastructure as well. So the proposal was there is going to be 2 adult centers. Lot 1 is northwest and northeast of England, including Yorkshire, the Midlands, north part of the east of England region, including Cambridge. This is adult inherited white matter disease. These things. Lot 2 will be London, the southeast, southwest England, the southern part of east of England region, including Essex. This This was from NHS England, and there will be 3 pediatric IWMD centers. So pediatric IWMD center, lot 3 will be northwest, northeast of England and Yorkshire. Lot 4 will be Midland, north part of east of England region, including Cambridge. And lot 5 will be London, southeast, southwest of England, southern part of east of England, including Essex. And there was another one, lot 6, that will be a separate bidding for inherited white matter disease registry service. This is an all-age registry. In itself, it's one of the services. It's going to require intense input from the team, inherited white matter disease team, and the support, because the registry will try and capture patients right from any age, either after birth, before birth, till the patient is in their old age. Registry, I think John would have spoken to you about it, but it is quite intense. And that type of information we are trying to capture is as much data as possible. So, and it is patient can report, parents can report, carers can report about their sort of follow-up and outcome stuff. So far, I don't know what other centers they have bidded. This is confidential information. I know we have bidded together for lot 5. That is the southeast, southwest of England, London, and I think till Essex, below Cambridge. And this bidding has happened jointly between Evelina and Gosh. So one center will lead, so this will be lot 5, but it will be based at 2 centers. And so far, our patients will be equally distributed. I will be leading this service from Evelina. Cheryl will be leading from Gosh. We have backup neurologists from both places, and the cost of this service, like whatever amount of money you are going to get, will be split between 2 teams. This will give us a unique opportunity to have, I think, in our active group, we have around more than 200 patients at the moment. And believe me, there is a significant proportion of patients who are undiagnosed. So we can use the expertise of both the hospital and the research network, and the Alexander's disease trial. The site has been is Gosh. They have not started recruiting yet, but they're still stuck with the ethics committee approval. And the other trial for Aicardi-Gouttiere syndrome with baricitinib and other medicine, that will be starting soon as well. So we think that if we are successful, then we have a good chance that we might become one of the biggest, or one of the big centers. And it doesn't matter even if we are not successful. I think as a joint effort in UK, this service needs to be there, and whatever centers are successful after bidding, I think we can work together to make sure that our patients get good care. We have bidded separately for lot 6 as well. That is the inherited IWMD registry. So we would be keen to host this registry, and that is from Evelina. So I don't know. I think there are 16, 17 centers. There are more than that they have bidded, and the outcome will be clear by the end of this year. And there is a plan we have made, which I'm going to talk to you. So the service in itself is tiered service. It's very clear that it's a highly specialist service. It is not service to take over care of a patient completely from the neurology, from the nearest center. So the tier 1 service is virtual. We get a referral. We have been at Evelina, we have been running this sort of service for 2 years now. So we get a referral about a patient, suspected MRI scan looks like leukodystrophy. So the lead clinician will discuss this in their radiology meeting. They will give them plan what to do. we don't need to see them face to face, and plan is given to them. They discharge back to local care, and if there is uncertainty, we will move to additional assessment at level 2 or level 3. So tier 2 is also virtual MDT. Here, either first patients referred from tier 1, 50% of them will have some sort of, we have given them plan, okay, do this, do these investigation, get back to us. So we will try and collate all the information, discuss with the metabolic geneticist and neuroradiologist. So currently we are having this MDT every Tuesday. So where people, we will say, okay, the diagnosis has been made, then either there will be a virtual consultation with the family, saying, talking to them about the diagnosis, what other things can be done, or if needed, if they want to see us, then they move to tier 3, and tier 3 is one-stop multidisciplinary team, face-to-face clinic, which will be held. Currently, the proposal is 6 clinics will be at Evelina, 6 clinic will be at Gosh. So every alternate month, we will have one full day clinic, MDT clinic there, where we will have multi-professional clinical review. So there will be undiagnosed inherited white matter disease, diagnosed with specific question from tier 1 and tier 2. And we aim to 50% of them will continue to follow up, to have an outpatient follow-up or reviewed by allied MDT, or if they need any specialist intervention like referral to spinal surgery, respiratory team, sleep team, cardiologist, those things can be activated. And all these, whether patients are in tier 1, tier 2, or tier 3, they need to be registered in inherit registry. So the registry coordinator for that inherited white matter disease service will be absolutely a database manager, and MDT coordinator will be a critical person, point of contact, and that person along with the clinical team will be able to keep an eye on the health of the data and everything. So there is a proposal for tier 4, that is once the patient has been, if they are recruited into any trial, so they will move to tier 4. So NHS England, so far they have that is the description, and I think with the way new gene therapies are coming up, we might have to think about how do we include tier 4 in that. That will be something for future. So currently, this is the implementation plan, and the service will go live from 1st of April 2022. So then after we expect to have a result by December. Then January, we have planned how do we mobilize the project meeting, virtual MDTs will be set up, joint business meeting with whatever center they are. Here it is GSTT Gosh, because that is how we have operationalized it. That is what we are thinking we are going to do if we are successful. Then if you see, we will develop a standardized referral form, establish service email address, schedule initial MDTs and clinic booking meeting and clinic rooms. And I don't want to read all of them, but this will get sort of better as time progress, once the service has started. And we will need help from Alex TLC. I had a chat with Sarah, and there is a good plan moving forward, which I'm going to talk later on. And this registry, bidding for disease registry center is equally important. And there is one funded band 4 coordinator, which NHS is not a big amount of money, but I think that's a good amount of money. And you see this logo, this has been designed by Alex TLC. And I think it will stay for the life of this registry. So far we have. Initially, we had just few lines, 1 or 2 strands. Then someone commented, it looks like blood vessel. Okay, put in some more white line, it looks like white matter. So this was designed by Alex TLC, and that will be our logo. So how will the registry look like? If John has mentioned about it, then it's quite intense, or I can talk about it later on. There are 5 sections. There will be a section where patient carer or patient carer parents, they will input some basic information. The MDT coordinator checks the data and agrees that, okay, this patient needs to be on the registry. Then you have clinical information sheet. First bit needs to be filled in by clinician, quite intense, trying to capture as many data as possible, radiological, genetic, metabolic, everything. Then there is a clinical follow-up section. Then you have patient follow-up section, and there's multiple options of multiple sort of every session will be logged in, and we will have information. There is a disability score to which has 5 domains, which is throughout, and there are some more questions which Sarah has put in after doing her survey with the patient group, that as to what they expected from registry. But my feeling is once registry starts functioning, we will understand the difficulties and other things, what comes up, and we might be able to change it. So there is an IWMD steering group. So they will sort of look at the day-to-day governance structure, research structure, some problems coming up. That meeting there will be 3 or 4 meetings per year. Steering group will give recommendation, which development committee will follow it through. And we do have inherited white matter disease national clinical meetings, 3 or 4 a year. So these three groups where we can monitor our clinical activity, look at the governance structure, see what changes needs to be done and what difficulties we face. And then the steering group and development group is not just clinician, they are patient support organizations. Important stakeholders are there from all other patient support groups as well. So this is what we are planning to sort of at the launch, these activities we will do, and as it moves forward, how we are going to monitor that. And you see 6 monthly data audit, 6 monthly data report, monthly review of incident log, monthly report follow-ups, and how patients are when they are due to be transitioned. So this has quite intense sort of follow-up program. So we want to provide a high quality and responsive service. So once the whatever centers have been successful in acquiring that, we will invite representative from patient support group and referring clinician to help shape the service. There will be 6 monthly patient and parent guardian engagement survey, provide reciprocal signposting by we already do that. If there's a patient, I do signpost, we do signpost to them, and sometimes Alex TLC, they tell us about the patient as well. We will involve patients will be involved in co-design of all the patient related information, guideline pathway, collaborate. We all 5 centers, 6 centers will work together with in the domains of development committees, like steering committee and the clinical meetings. We anyway meet with the clinical meetings, and it will become more structured, more formal, I think. Clinically, what we are expecting that we facilitate appropriate support for patients, whether there's a support from other wider MDT team, whether it is a support for changing medicine to optimize their sleep. And so far, referring team, they have been quite responsive, and some parents, they just want to talk about this thing, and we have been able to provide some support. Not made much. These things, trials are still waiting, but these things are work in progress. Early diagnosis and screening, that will be a big group with the way Genomics England, they have the new service has started. I'm sure we will be able to. We do see fetal cases. Sometimes there's a family history of Canavan's disease, and the baby is born. The screening is done early, like many other conditions. So we aim, and there are new conditions we are finding, like new gene, new leukodystrophies. We want to be engaged, fully engaged with emerging and future therapies, and undiagnosed inherited white matter disease. quite a significant proportion in our cohort. So we have already started going back and looking into them and seeing if we can make a diagnosis. It's important for them, it's important for their families, and facilitate recruitment in various trials, nationally or internationally. We would aim to get the trials to us. I've seen patients, two of my very important patients with vanishing white matter disease, they died before they could be recruited. So if we can facilitate those trials to come to our center, and we have already been collaborating with international experts, they come for our meetings, and we aim to keep that going on, this thing. And patient engagement and experience activities, that satisfaction survey, the community days, what what you are doing now, we want to engage completely with that. Sorry, I couldn't attend the whole day yesterday and today, but in future, maybe I need to look at my job plan, and I need to spend time, more time with you guys, and continue to provide medical advisory support for diagnosis or modification, anything which needs doing. So this was an initial sort of data, but I think because we have not systematically collected these data, so things will change. And I think in 5 years' time, we will see altogether, if we manage to run this service properly, we will see a different cohort. We will understand the incidence and prevalence of these conditions and in a better way, and see how many of them requires what investigation. Now with the genetic thing, you don't do thousands of investigations. Sometimes you wait for the genetic results to come back first. So let's keep our